Good morning, ladies and gentlemen. A warm welcome to all of you who are present here for the Infectious Diseases Conference 2025, hosted by the Infectious Diseases Forum of the Ceylon College of Physicians in collaboration with the International Society for Infectious Diseases and Clinical Infectious Diseases Society of India. This is the second edition of the Infectious Diseases Conference, which will be held over the course of 2 days. It's being held with aims to foster discussions, especially focusing on common and emerging infectious diseases that are relevant to Sri Lanka, and also to exchange knowledge among experts in the field. Before we commence today's proceedings, ladies and gentlemen, please rise for the Sri Lankan national anthem.
Sri Lanka Mata, Abba Sri Lanka, Namo 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 Mata. Sundara Sri Karini, Surani Api Sobhamana Ranuha. Ranya Nana Nekaman Walaturi, Jaya Bhumi Ramya. Apahata Sapasi Sita Sadhana, Jivana Hemada. Pilitanu Mena Apabhakti Puja, Namo Namo Mata. Abba Sri Lanka, Namo 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 Mata. Upavi Apavidya, Upanaya Apasatya, Upave Apashanti, Apahata Kulabhakti, Upa Anuki, Apagi Anuprani, Upa Apajivaname, Apamuktiya Upave. Navajivana Divini, Likita Apatubunukaran Vata. Jnana Pina Vadavani Nirajinayanu Menajaya Bhumikara. Ikkamavaka Kedanu Kalavedina, Yamu Yamu Vinopama. Premavada Sarveda Durala, Namo Namo Mata. Abba Sri Lanka, Namo 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 Mata.
Please resume your seats, ladies and gentlemen. Before we commence today's proceedings, ladies and gentlemen, I now invite Dr. Vimalasiri Uluwatage, convener of the Infectious Diseases Forum of the Ceylon College of Physicians, for the opening remarks.
Thank you. Good morning. Professor Prasad Katulanda, the President of Ceylon College of Physicians, distinguished international delegates, esteemed resource persons, colleagues, and friends. As the convener of Infectious Disease Forum of the Ceylon College of Physicians, it's my great honor and privilege to warmly welcome you to the second International Infectious Disease Conference, IDC 2025. At the outset, I would like to express our deep gratitude to Professor Katulanda and the Council of Ceylon College of Physicians for their unwavering support, vision, and commitment in making this conference a reality. Your leadership has been instrumental in strengthening the role of infectious diseases care in Sri Lanka. A heartfelt appreciation also goes to our international collaborators, Professor George Varghese, President of the Clinical Infectious Disease Society of India, and International Society of Infectious Diseases, ISID, represented here by its President-elect, Professor Neelika Malavige. Your commitment and continuous collaboration enrich the scientific depth and global relevance of this conference. I also wish to sincerely thank my dedicated secretaries, Dr. Nilanka Pereira and Dr. Dumita Govindapala, as well as the entire executive committee of the Infectious Disease Forum for their tireless efforts and exceptional dedication in organizing this event. The Infectious Disease Forum, established in 2021 as a permanent standing committee of the Ceylon College of Physicians, it was born out of necessity. While infectious diseases are not yet recognized as a separate specialty in Sri Lanka, the growing burden of infections and the rapid expansion of the knowledge in the field made it clear to us that a focused, multidisciplinary platform was urgently needed. Thus, a group of physicians came together to form a collective that brought together clinicians, microbiologists, public health experts, and researchers, recognizing that the infectious disease control is not the task of one discipline alone, but done with multidisciplinary approach. Our primary objectives have been clear from the beginning: to promote knowledge sharing among medical professionals, to foster research collaboration, both local and international, to play a pivotal role in formulation of national clinical management guidelines, and to provide a strong professional voice in public health advocacy on infection control. In line with these goals, we launched IDC, Infectious Disease Conference, as a biannual international conference. The inaugural event in 2023 was a resounding success, and with enthusiastic participation from both Sri Lankan and international delegates. Over the past 2 years, we have been privileged to build strong ties with global leaders in the field. Notably, Ceylon College of Physicians has recently signed an MOU with the Clinical Infectious Disease Society, enabling joint research initiatives and clinical training opportunities in India for our members. We also maintain active engagement with ISID and the Infectious Disease Society of America, IDSA, through knowledge sharing and shared academic activities. At the national level, IDF is currently leading the development of several clinical guidelines in collaboration with Ministry of Health, covering leptospirosis, melioidosis, and dengue. We are also deeply involved in tackling antimicrobial resistance, working with the pharmacists, pharmacologists, and prescribers to develop educational modules for rational antimicrobial use. As a middle-income country, Sri Lanka faces a rising tide of infectious diseases, compounded by an aging population, a growing diabetes population, a prevalence increasing immunocompromised states due to cancer therapies and transplant, and also the ongoing threat of emerging infections. The need for innovation and preparedness has never been more pressing. In fact, the current global alerts suggest we may be standing on the brink of another COVID-like outbreak. We also recognize critical gaps in diagnostics, in national policy implementation, and in coordinated infection control efforts. Our aspiration is for the IDF to evolve into a national platform that informs both policy and clinical practice on infectious disease in Sri Lanka. To do this, we need to build a broader coalition. I take this opportunity to extend an open invitation to young clinicians, diagnosticians, researchers, and healthcare administrators to join us, because tackling infection diseases is not just a professional imperative, it's a national responsibility. Finally, I wish to thank all our esteemed resource persons in advance for their valuable contributions, and I warmly welcome all participants, both in person and joining us virtually. I trust IDC 2025 will be an enriching, inspiring, and impactful experience for all. With that, I am honored to declare the Infectious Disease Conference 2025 officially open. Thank you.
Thank you, Dr. Uluwatthage, for that wonderfully thoughtful address. Now, I invite Vidya Jyoti, Professor Prasad Katulanda, President of the Ceylon College of Physicians, to share with us his insights.
Good morning, everyone. It gives me great pleasure as the President of the Ceylon College of Physicians to warmly welcome all of you to this infectious disease conference organized by the Infectious Disease Forum of the Ceylon College of Physicians in collaboration with the Infectious Disease Society and Infectious Disease Society of India and all the other societies. I would like to mention Dr. Vimalasiri Uluwatha, the chairperson of the Infectious Disease Forum, Dr. Nilanka, and Dr. Dumita Govindapala, and all other officials of the Infectious Disease Forum of the Ceylon College of Physicians, and also esteemed officials of the ISID, IDC India, Infectious Disease, Clinical Infectious Disease Society, and all other collaborating partners of the IDC 2025. I feel quite proud and humbled as the President of the Ceylon College of Physicians at this inauguration ceremony, where we are having a stand-alone conference for infectious diseases by the IDF of the Ceylon College of Physicians. Let me first begin by congratulating and thanking Dr. Vimalasiri Uluwatthage and his team from the IDF for this great effort. And also I understand and I see that this year's program is enriched by experts in the field of infectious diseases from countries like United States, India, Pakistan, United Kingdom, South Korea, Singapore, and of course from Sri Lanka. I think this conference gives us a great opportunity to share knowledge and network and work together in this common theme of infectious diseases, particularly touching on very important topics like the antimicrobial resistance, emerging infections, re-emerging infections, infectious diseases related to travel, and fungal diseases, and so on. And also, there is a lot of opportunity for bridging between disciplines. So I see this great opportunity with this conference, and we are not just talking about the biological impact, but broader context in the global equity, preparedness, and stewardship, and on scientific diplomacy, particularly in relevance to the infectious diseases. And particularly, I'm proud to see that we have sessions like Right Drug, Right Way segment, and also zoom out to systems thinking with discussions on antimicrobial stewardship, vaccination frontiers, immune-based therapies, and many novel aspects. And also, the ID quiz gives a lot of opportunities and make it quite interesting for our young trainees. And as we celebrate and mark the growing strength of the research on infectious diseases by Sri Lankan scientists, in line with our broader theme for the year, Physician for the Future, we are preparing our physicians to deal with the dual pandemics of non-communicable diseases and infectious diseases together. As you are aware, the impact of both become quite marked and dramatic when there is both occurring together. And we saw this very clearly in the COVID pandemic, where the people who succumbed to COVID were mostly people with chronic NCDs. So in this context, taking back infectious diseases which were a bit neglected during perhaps the pre-pandemic era is very pertinent. Again, in closing, let me again congratulate our team who organized this event with perhaps little support from the main committee. So I'm really grateful to all of you, Vimalasiri, Nilanka, Dumita, and the team. And also our esteemed faculty, both from overseas and Sri Lanka, and also I'm very grateful for all these international bodies who have joined hands with the IDF of the CCP for being here. And for the participants, let's make this not just a listening experience. Participate actively, ask questions, give your experiences. You may be a registrar who had seen one of the rarest complications of dengue or chikungunya, which even the international experts would not have seen. So make it an active learning experience, and I'm quite confident and happy to see that we are going to have a great fiesta of learning, sharing knowledge, networking on infectious diseases. Thank you very much again.
Thank you, Professor Katulanda, for sharing with us your insights. Before we dive in, here are a few housekeeping notes. Please silence your mobile devices. The book of proceedings containing the program can be accessed by scanning the QR code, which will be displayed over at the registration desk and all the tables. Now, without further ado, let us move on to the initial segment to set the tone for our 2 days of learning and discussion, the keynote address. This will be chaired by Vidya Jyoti, Professor Prasad Katulanda, President of the Ceylon College of Physicians, along with Dr. Vimalasiri Uluwatage, convener of the Infectious Diseases Forum of the Ceylon College of Physicians. It is with pleasure that I invite Professor Katulanda and Dr. Uluwatage onto the stage. Thank you.
Good morning again. And welcome to the first keynote address on the subspecialty of infectious diseases, lessons learned. Our speaker is an esteemed scholar on infectious diseases, Professor P.H. Chandrasekhar. It gives me great pleasure to introduce Professor Chandrasekhar, who was born in this same here soil, and then he has served as Professor of Medicine and Infectious Diseases over 40 years at Wayne State University, Detroit, Michigan, and also many responsible positions as Chair of the Department of Infectious Diseases, the Program Director of Infectious Diseases Fellowship Program, and in fact, he, for his work and academic acumen, had been recognized as a Fellow of the American College of Physicians and the Fellow of Infectious Disease Society America. He had served as the President of the Michigan Infectious Disease Society from 2021 to 23, and his main interests include infections among immunocompromised hosts, particularly those with cancer and those underlying hematopoietic stem cell transplantation. After recent retirement, Dr. Chandrasekhar is involved with medical education globally in the field of infectious diseases. Dr. Chandrasekhar is promoting awareness of infection, particularly in countries where the field of infectious disease is not identified as a subspecialty of medical practice. And I take great pleasure because I also work very closely with the Michigan University in the area of diabetes to welcome you here and invite you to deliver your keynote address.
Thank you. I hope you can hear me. Can you hear me?
Yeah, we can.
Excellent. Thank you and good morning, everyone. Thank you for this honor. It gives me great pleasure to see the Infectious Disease Forum has convened this meeting to promote awareness and for the betterment of all Sri Lankans from the standpoint of better control and better management and better prevention of infectious diseases. And I'm sure this forum will be just the beginning for many, many more good things to come. And I was asked to speak about subspecialization in infectious diseases as a need in Sri Lanka. Thank you for this honor and the privilege. And what I would like to do is, as the person who introduced me said, I was born in Sri Lanka, and I attended St. Benedict's College in Kotahena, Colombo, after which I found my way to India, where I completed my medical school at Christian Medical College, Vellore, and then I found my way to the US for a career in infectious diseases. And I have lived in Michigan for the past 4 decades and dedicated my career to the field of infectious diseases. I've been in close touch with what's happening with infectious diseases, both in India as well as in Sri Lanka for the past few years. And I'm very glad to see where we are today. So what I would like to do is to talk a little bit about infectious diseases globally, and then try to talk about the beginnings of infectious diseases in the United States in the 70s, how it has matured over the last 20 to 40 years, and then talk a little bit about the subspecialization creation in India, and then finally close with the potential for Sri Lanka to take up the same challenge. So let me get started. As you can, I hope the slides are clear to everyone. As you can see, this is a 100-year span of time looking at all causes of mortality around the globe, and particularly in the United States. This is concentrating on crude mortality rates for all causes, non-infectious causes, and infectious diseases. As you can see here, clearly all-cause mortality has dropped, and the primary reason for the drop in the all-cause mortality is infectious disease drop. We are all very happy to see the drop, particularly in the after 1940, okay? And if you look at the infectious diseases by itself, you can see how since early 1900, there has been a steady drop contributed to by municipal use of chlorine in the water. Chlorination was introduced in the early 1900s, and that led to a substantial reduction in infections in the United States. There was, of course, the influenza pandemic, which took away millions of lives. And then you can see the plague pandemic started there. And then antibiotics were introduced in the 40s. So the first big drop was chlorination of water. The second big drop was introduction of antibiotics. And then in the 50s, the introduction of vaccines. These three crucial things had led to a substantial reduction in infections in the United States. And then, of course, in the early 60s, there was a Vaccination Assistance Act was passed, and that compelled children to be vaccinated, and that led to substantial reduction overall in infectious diseases in the United States. However, if you see the last few years, there has been a slight uptick, and this was probably due to the COVID pandemic that led to, and the HIV pandemic followed by the COVID pandemic that had led to this bump in the infectious disease mortality in the last few years. Now, if you look at the United States, my first few slides, I'm going to be talking a little bit about how in the US, the need for infectious disease as a specialty was born. This slide essentially describes that. In the late 70s, there were several factors that compelled the need for creation of infectious disease as a specialty. What were those reasons? There was cost of care from infectious disease was steadily rising. There was an increasing demand for ID consultations because of the workload of infectious diseases increasing in number in the communities as well as in the hospitals. However, we began to see common infectious diseases becoming less common, and there were uncommon infectious diseases, opportunistic infections, as immunocompromised host population began to increase. We began to see a wide variety of infectious diseases. And there had to be somebody who had to be able to interpret the clinical findings and the laboratory results, connect the two. And the demand for this kept rising steadily in the late 60s through the 70s. There were a lot of uncommon pathogens. Legionnaire's disease is a typical example of one of those uncommon pathogens that took the lives of hundreds of thousands of individuals. And then finally, there was a whole array of antimicrobials started coming into the picture, and consequently antimicrobial resistance began to occur as well. All this compelled the need for creation of a separate specialty, as the existing physician groups could not cope or felt that was beyond their area of expertise. So everyone agreed at that point an ID specialty had to be created, and that's when it was. So I became an ID specialist in the early 80s through the American Board. And at that time, already the specialty had been there for over a decade, easily. With ID specialist involvement, since then, there have been several prospective and retrospective studies, as you can see on the slide, that clearly demonstrated ID specialist involvement led to better diagnosis of infections, faster diagnosis of infections, shorter length of stay in hospitals, patients had developed fewer complications as a result of infection, and the need for antibiotics, the use of antibiotics became better. There was better usage of antibiotics, and clearly certain common illnesses like Staph aureus infection with ID consultation proved to be of great benefit. So these have now been well documented through very well conducted studies, documenting the usefulness of having an ID specialty. Now, this has been borne out. These are insurance large claims data sets. As far back as 11 years ago, as you can see, there was a very large sample size that was looking at with ID consultation, over 100,000 through 2008 through 2009. And there were no ID consultations in over 170,000 individuals. And these were propensity score matched. And we can see with ID consultation and without ID consultation, there was a significantly lower mortality and lower readmission rates in patients who were admitted originally with infectious disease. And if ID consult was obtained within 2 days of admission, the 30-day mortality was less. There was reduced hospital and ICU length of stay, and the payments were similar. Okay, so all these were clearly shown through data. Here is another study that again showed this was a transplant population. You can see length of stay with an ID consultation. The p-value was substantial, and hospitalization cost again was significantly different, much less if an ID consultation had been obtained. So in the United States, with the introduction of the subspecialty, the people benefited when ID consultation was obtained. There are about 10,000 board certified ID physicians today. Most of them are in private practice. Academic practice, there were a few people, a small proportion of individuals, either serving as clinician educators or bench investigators. Private practice can consist of solo practice or group practice in hospitals. If they become hospital employees, they are paid a stipend, and the hospital physicians, as ID physicians, need to provide infection control for the hospital, antimicrobial stewardship for the hospital, and play a very key role in pharmacy and therapeutics committee. So as you can see, this is the rough structure of an ID specialist in the US, either in private practice or in a small proportion of physicians working in university setups. But most of the hospitals today, whether they are small or medium-sized or large hospital, today they have infectious disease practitioners either working within the hospitals or outside the hospital and providing consultative care. In the US, there are about 140 or 45 infectious disease training fellowship programs created. This slide is a little old. It shows 137. In the past few years, few more programs have been added. Each year, we see about 300 to 350 graduates graduating from various fellowship programs after their postgraduate degree in medicine. It's usually a 2-year training program, and at the end of 2 years, they become board eligible, and then they are certified with ABIM once they pass their boards. And then what happens to them? They can either be on the clinical track as fellows during their fellowship, or they can do a clinical investigator track as an extra year after clinical fellowship, obtaining more investigative training on the clinical field. If they want to be doing basic science work, then they can do extra years, either additional 1 or 2 years in the lab doing basic investigator track. So these are the 3 classical tracks we utilize in training postgraduates in medicine in the field of infectious diseases. At Wayne State, where we trained a large number of individuals, we provide 1 year of clinical training and 1 year of lab-based training during their 2 years of traditional fellowship. And of course, additional years, as I said, are optional. During this period, they are trained how to write manuscripts, how to present at national meetings, in addition to, of course, good clinical care of patients. Now, what happened in the 2000s? All of a sudden, we began to see a declining demand in the infectious disease field. That led me and a couple of others to join together and publish an article in the leading journal in the United States, Clinical Infectious Disease, as a viewpoint, saying maybe there is a declining demand among youngsters choosing infectious disease. And that was demonstrated by this graph. As you can see, this graph depicts all the different subspecialties of internal medicine. As you can see, the number of unfilled programs, training programs, over the total number of programs are depicted in this graph. As you can see, infectious diseases has the largest number of unfilled programs around the country of their fellowship programs, closely competing with nephrology. So we began to see there was a declining demand, fewer people applying for infectious disease fellowship. After the creation in the 70s, within 20, 30 years, we began to see a declining demand. Okay, this is worrisome. If you compare that to other subspecialties, cardiology, pulmonary, rheumatology, GI, and so on, the demand was a plateau. They had consistently maintained a good demand of young physicians going into those specialties. In contrast, nephrology and ID took a nosedive. Why? Why did this happen? The Infectious Disease Society of America became concerned, and as a result, this led to several different moves by the Infectious Disease Society and a variety of other groups. As you can see, this slide summarizes the various efforts that was created. Went back to the roots, went to the medical school curriculum, microbiology was strengthened, and medical students, residents, and fellows, they were better mentors. They were provided with mentoring opportunities, scholarships, funding research was provided to various programs, and in general, the compensation had to be addressed. ID specialists as a whole were not compensated very well, and therefore IDSA has had numerous discussions with the compensating bodies, hospitals, the government, etc. And as a result, the compensation has considerably improved. Their career opportunities have expanded, and we had to document the value of having an ID specialist in cases. And overall, there has been a steady increase of satisfaction for people choosing to do IDs as carriers. Okay, so many surveys have been conducted. Task forces have been created to look into the exact reasons why there had been a declining demand, particularly in terms of compensation and introduction of the specialty at a very, very early stage. To my surprise, I found many medical students were not even aware that infectious disease was being offered as a specialty. So by the time they became residents, they had already chosen in their mind to become a gastroenterologist or a pulmonologist, and they were not even aware that ID was an option. So we had to introduce ID at the medical school level and make it a point to have several special separate hours dedicated to contact the ID specialist with the medical students. And I think all that eventually made a big difference. Our compensation improved. We documented value of the contribution of the specialist, and medical school curriculum inclusion included stewardship, infection control, and importantly, the IDSA started interacting with a variety of other societies. And I'm happy to say, as you can see, in the last few years, this is 2 years ago, ID, now the positions filled had risen to 75% of the programs filled their positions. And that is very comparable to other programs such as palliative care. We have considerably improved. We're not anywhere near as cardiology or HEMONC or GI, but we have made improvement. So I think there is still a long way to go. We have learned lessons how to improve or how to attract younger physicians into the field of infectious disease. Sorry. So what is the average workday of an ID doctor in the United States? Mostly patient care, inpatient rounds. We do consults, follow-ups, sign-offs. In the outpatient setting, we have outpatient clinic, hospital discharges and referrals, with or without additional support with the fellows or with physician assistants. This is the bulk of our time for clinicians. Teaching, ID fellows, residents, and students. Bedside teaching consumes a lot of our time. And more importantly, IG education for the nurses, for other subspecialists, for other personnel in the hospital. We contribute tremendous amount of ID education, and that consumes a fair amount of time. Administration-wise, we participate in infection control along with infection control practitioners. We play a very important role in antibiotic committee that is run by the pharmacy, and pharmacy has ID input, including other important stakeholders, microbiology team, surgical specialists, ICU docs, and infection control. And this team is in charge of designing the antibiotic formulary for the institution, developing policies and guidelines for the institution. Now, documentation is done at the end of the day. After my work is completed and the ward rounds are done, I walk back to my office, sit down, sign all the patient notes, and write my notes as well. And this is done, and during the entire day, there is constant communication with the microlab, pharmacy, and infection control. And this is on an average what an ID doc's life is like. Now, let me move to India. So this is what we accomplished in the United States, and it's flourishing now, the field. Now, in India, there were a lot of challenges. This is some years ago. I put together this slide. Again, the need for an infectious disease to be created as a subspecialty. Frequency of infection was increasing. I'm talking about in the 80s at this time. Poor infection control, awareness and implementation was scarce. There was inadequate knowledge among physicians, patients, as well as, importantly, administrators. Resources have been limited. There is poor infrastructure as far as infectious diseases was concerned. Laboratories were poorly equipped in terms of modern diagnostic techniques for diagnosing infections. Particularly molecular laboratories were non-existent. Poor communication between labs and the clinicians. Antibiotics were rampantly abused. Antibiotic resistance was on the rise. And clearly all this in the absence of ID as a subspecialty. And to top it all, HIV pandemic started in the early 80s. So you can imagine this is a perfect storm. Okay, there was a clear need to create infectious diseases in India. So we can see the antibiotic consumption was also high. All the classes, antibiotic uses had gone up, particularly with beta-lactams, and not surprisingly, as a result, there was antimicrobial resistance. So there were several proposals that had been provided. People were brought in, slowly infectious disease programs were initiated. Several of the people went overseas to be trained in infectious diseases. Many of them came to Wayne State. I had the privilege of having several people at our institution, and many of them had returned back to India and started infectious disease programs in various parts of the country. And 5 particular areas I have to mention that how the clinical training was being provided. And what are those areas? Clinical training in diagnosis and management of common, uncommon infectious diseases, emerging and re-emerging infections. This was all provided by, you can see, available experienced clinicians, increasing pool of trained infectious disease specialists who were trained either overseas or within the country, mostly overseas, and they had come in, a small pool, and the trainees may be sent abroad to specialty centers. That was point number 1. The second, lab-based training, basic microbiology, mycology, mycobacteriology, parasitology, virology methods of diagnosis, basics of molecular biology, antimicrobial susceptibility and resistance. And who would provide this training? I think this would be provided by the university-based microbiologists for the trainees in India. And training in infection control and epidemiology if they are to function as ID-trained clinicians. And they would obviously have to be well trained in the field of hospital-acquired infections as well as antimicrobial stewardship. Here again, the training would be provided by the existing pool of trained specialists, internet resources, and through a variety of courses and conferences. And training in infection control, we went through that, and increasing employment opportunities. This is very important. And not only do we have the obligation to train people, but also to find them adequate employment. And these infectious disease consultants have to be compensated optimally. And they would be in charge of constructing policies and for control of nosocomial infections. And why should the hospitals be interested? Pretty obvious. Decreased resistance emergence, decreasing nosocomial infection, decreasing mortality, will certainly associated with a decrease in liability. All this will save money for those institutions. And finally, fostering aptitude for research, providing time during the training, identifying the good mentors, providing proper training, international collaboration, training them in better grantsmanship, and improving writing skills. So all these various factors, they're classified into 5 different categories, I think needs to go into any country that is looking into the possibility of starting ID fellowships. Now, as a result of all these efforts that have been made in India, you can see how much India has come forth since the 90s. This is more recently, there is an increasing number of training programs. Clinical ID Society of India has been created with increasing attendance every annual meeting, increasing visibility, not only within India, but outside of India as well. As you can see today amongst you, antimicrobial resistance has received considerable amount of attention through the efforts of various infectious disease specialist contribution. A DM program has been initiated through the central government of India in several states in the country. And here again, there are more and more trainees, well-trained individuals coming into the mainstream of the physician population to provide specialty care in infectious diseases. Now, There is an increased interest among hospital administrators as well, because they have a better standing with JCO. This is the committee in charge, which gets the approval. If JCO approval is obtained in a hospital, obviously they have a better standing internationally. And they have better reimbursement potential as well. So that, therefore, the hospital administrators are interested in having JCO certification, and therefore they have a special interest in having infection control, antimicrobial stewardship instituted within the institution. Okay, so as a result of all this, India has come a long way as established as a separate subspecialty. Now, what about Sri Lanka? As you can see, now some of these slides for Sri Lanka, I must thank Dr. Nilanka Pereira, was kind enough to give me these slides, the information. I was amazed to see through that information the amount of public health achievements that have been made in Sri Lanka. Many of these diseases have been eliminated completely. Okay, these are fantastic success in terms of public health. There's an epidemiology unit that is available now. I guess that is the equivalent of CDC with a notifiable disease surveillance unit that has been created. And there are control units around the country to control diseases, including dengue, rabies, leprosy, TB, and STD. All these are providing excellent control of many of these infections. Now, there is a free healthcare system. I don't need to tell you, you guys know this. This is something Sri Lanka ought to be very proud of. And who is in charge at this time in detecting, preventing, managing infection? There are primarily internal medicine doctors, clinical microbiologists, and public health physicians. These three strata of individuals are involved in policy making and guideline development. And I believe with the support of these three groups of individuals, an infectious disease specialization can be created, and that individual can complement the services provided through these three strata of care providers. So in summary, area of all aspects of infection, including management, is vast and complex. We understand infectious diseases are becoming a lot more complicated than what they used to be. Number one, creation of the subspecialty of infectious disease in the United States clearly contributed to improved management. So I showed you there's plenty of data available with infectious disease presence and without the subspecialist presence. There was a vast difference. And this has been felt very strongly in the United States. India, in the past 20 years, has clearly seen the benefits of the creation of this new subspecialty. Fostering young physicians in Sri Lanka into this field is likely to enhance infection management in both hospitals as well as in communities. And I have no doubt about that. And I hope further measures are taken and there is active involvement through various individuals, including public health officials, microbiologists, and general physicians, taking an active interest in creating this specialization of infectious diseases as the area itself is becoming more and more complex, harder to manage. And therefore, it deserves a separate subspecialty attention. I thank you for this opportunity again, and I can't tell you how happy and grateful I am for having had this honor asking me to give this keynote address. Thank you.
Thank you, Professor Chandrasekhar. As a person who has seen and witnessed all three stages of evolution, I would say of infectious diseases and as well as the infectious diseases as a specialty in the world, especially in our part of the world. And you are the best person to give this talk. And thank you very much for that very informative and very thought-provoking lecture. And to add something, and Sri Lanka, as you said, we are at a very primitive stage, preliminary stage of infectious disease specialties as a subspecialty. But the idea of IDF is not to create ID as a specialty, because it's up to the authorities, and there is a strictly regulated mechanism in Sri Lanka to recognize specialties. So that is up to the authorities. But what in the IDF, what is our aim is to make an awareness of our internists as to the knowledge gap that is existing between the medical fraternity and around the world, because this is a fast-moving, fast-spreading, and fast-developing field. And also, we have a significant gap in the diagnostics. And also, there is a huge difference, or the huge vacuum in the control of infection. We are not, our organization, even though we have achieved several milestones, and we have some deficiencies, just to make you, our physicians, aware and address. So that is the aim of IDF. And with that, we conclude this session. And thank you very much, everyone. Thanks.